talk on atrial fibrillation in Asia and globally. So that's my title. And firstly, this is my declaration of interest. I'm not going to read every line, but put into context everything I say or speak in this presentation with regard to these declarations. We're talking about atrial fibrillation, and this is, of course, a global problem. This is not unique to Western populations. This is not unique to Asia. It is a global issue. And as you can see from this presentation here, the burden of atrial fibrillation in the Asia-Pacific region. And these are from the different countries, the estimates of the total number of cases of atrial fibrillation in the different parts of the world, with 80 million cases in the Asia-Pacific region. But put into context, the Asia-Pacific region here, as you can see, and given the size of the Asia-Pacific region compared to the European Union and compared to the United States, clearly in terms of numerical numbers, far outweighing the European and United States data. So a big burden of atrial fibrillation in this region. I think it's important to understand the uniqueness between the different populations with regard to bad outcomes. And as you know, with atrial fibrillation, one of the most common outcomes relates to stroke. And this is an ecological epidemiological study that we perform comparing Asian and British white populations with regard to stroke. And this is using Korean population data, as you can see, and compared to white British in the UK Biobank. But in terms of looking at the risk, the incidence rates, I think you can see in terms of all strokes, in terms of ischemic strokes, in terms of hemorrhagic strokes, as well as atrial fibrillation related strokes, the higher incidence rates in the East Asians from Korea compared to white Europeans in the United Kingdom. So I think it's important to show the the differences between different regions of the world, the burden of atrial fibrillation, and this is related to ischemic and hemorrhagic stroke and the population differences. Stroke risk factors also differ in different regions, and I'm going to take as an example female sex as a risk factor for atrial fibrillation related stroke. This was, of course, very topical because for many years the female sex was included in stroke risk stratification schemes such as the CHA2DS2-VASc score. The recent 2024 European guidelines dropped the female sex criteria and just went for the non-sex CHA2DS2-VASc or the CHA2DS2-VA. But in terms of sex as a risk factor, I think if you go through the epidemiological data, being female was associated with 20 to 40% higher ischemic stroke rate compared to males in patients with atrial fibrillation. So you can see how female sex was a risk modifier and therefore incorporated into the CHA2DS2-VASc score. And there was very clear underuse of anticoagulation, particularly in women, and women tended to be undertreated in terms of evidence-based therapies in patients with atrial fibrillation. And should strokes occur, they tended to be more severe and disabling. Well, what's happening more recently, you can see here in terms of, on the left, Finnish data between 2007 and 2018. 2007, you see this clear female versus male differential in terms of ischemic stroke. But by the time you come to more recent data, there's hardly any difference. So these are Finnish data. And we also published this with Danish data between 1997 and 2020. You will see this female-male differential between higher stroke odds in the female patients compared to males. And by the time you come to 2020, this is not significantly different, as illustrated with the relative risk here. Hence, in Europe, at least, or rather, shall we say, in Finland and Denmark, especially in contemporary data, where there's hardly any difference here, you can see that how would the respective scores perform. So we did this formally and published. Anything below the little dotted red line indicates that the CHA2DS2-VASc score performs better than the CHA2DS2-VASc score. That's the non-sex CHA2DS2-VASc score. So you can see in 2007, when there was this clear female-male differential, the CHA2DS2-VASc score made sense, and it actually performed better than the CHA2DS2-VASc score. But by the time you come to 2018, you will see that this is not significantly different, especially there was hardly any male-female differential. But in different regions, you see stroke risk stratification differs. These are East Asia there. These are from the Taiwan National Registries, as you can see. Between the year 2000 and 2021, female patients, the incidence rate ratio, female patients, over the 2 decades, female patients consistently have a higher ischemic stroke risk compared to males. So there's no difference over 2 decades here. So if you formally compare the scores, you will see here, this is the net reclassification. Even between 2000 and 2020, consistently, the CHA2DS2-VAS score performs better than the non-sex version, i.e. CHA2DS2-VA. This is integrated discrimination index. So initially, for most of the years, the CHA2DS2-VAS score performs better, is in latter years becomes non-significant. So what you can see here in terms of risk stratification, what was seen in European data, i.e. Denmark and Finland, may not reflect all populations globally. And there's perhaps many reasons have been postulated, but I think it's to be clear that you may need population or region-specific data to drive recommendations for stroke risk stratification. So let's turn now to managing atrial fibrillation. Now, there was the perception maybe 20 years ago that you started a patient anticoagulation, that's your job done, you can discharge the patient. But I think what we now recognize that atrial fibrillation management is more than simply anticoagulation, because there remains this residual risk despite anticoagulation. This is a nice systematic review and meta-analysis that despite anticoagulation, the residual recurrent risk of AF-related stroke and then furthermore mortality, furthermore major adverse cardiovascular events remains high despite anticoagulation. Hence, if you go to any textbook of medicine and you go and look at a chapter on atrial fibrillation, what does it actually cover? It covers stroke prevention. It covers the management of patients' symptoms focused on rate control or rhythm control. And given the elderly population and multimorbid, addressing cardiovascular risk factors, comorbidities, and lifestyle type changes. Why is it important to emphasize this holistic or integrated care type management? Because the atrial fibrillation is so common. It's not just managed by general practitioners. It is managed in the emergency room. It's managed by many non-cardiologists. And even within the cardiology department, that's the arrhythmia and the non-arrhythmia specialists. So clearly, our patients with atrial fibrillation deserve surely a simple and streamlined approach and practical approach to their care and their management. So before the patient even starts these steps, we need to improve the awareness, the detection of patients with atrial fibrillation. So you can see how guidelines have evolved towards this concept of holistic or integrated care management. So this is a figure from the 2023 US guidelines, which describes this as the pillars of atrial fibrillation. So you can see here stroke risk. So the acronym is SOS, stroke risk. Then we have optimized and modifiable risk factors. Then we have the symptom management with, as I described, for rate and rhythm control. Now, in Europe and in many other, in the Asia Pacific Heart Rhythm Society, in the China guidelines, American College of Chest Physician guidelines, we have the ABC pathway. A, avoiding stroke, B, better symptom management, rate and rhythm control, and C is the cardiovascular comorbidities. This is color-coded, so you can see how they are related to each other. You can see with the color coding that we're talking about equivalent components, but I think it's important is how you ultimately deploy this, because think about atrial fibrillation being so common. You see maybe an elderly patient with atrial fibrillation, not many symptoms, multiple comorbidities, slightly scared coming to you in the office, in the clinic. Well, what can you do? You can say, well, your management plan is easy as ABC. You go, A is this, B is this, C is this. That's how we're going to manage you. You can take the approach that you tell this slightly scared patient, it's an SOS. I need to manage you as an SOS. Or in the European guidelines, it now has the acronym Scrabble has changed to become CARE. So it's color coded again. It's largely saying the same things, as you can see. So telling this patient who is already worried coming to you that in terms of the management of their atrial fibrillation, we have to handle you with care. Ultimately, we are saying the same thing, but it's important what is provided or what is supported by evidence rather than eminence. So what's evidence? Well, if you go by the ABC pathway, and this is a systematic review and a meta-analysis of in terms of the observational data, particularly, as well as cohort data, prospective studies, you will see that adherence to the ABC pathway translates to a over 50% significant reduction in mortality, a 39% reduction in stroke, and a 23% reduction in major bleeding. So evidence-based, not eminence-based. And in terms of prospective randomized trials, and this is highly relevant to this Congress since the evidence has been generated in two prospective randomized trials conducted in China. There's an ongoing European trial called AFFIRMO, which will hopefully report next year. But in the MARFA trial, this is done together with Professor Guo Yutao, who was my colleague in the 301 hospital in Beijing. The ABC pathway was delivered with an mHealth approach, and you will see here the primary outcome in red, the ABC pathway intervention significantly better than the usual care clusters by about 60% reduction. This was evident in all the high-risk subgroups. In terms of secondary outcomes, this is largely driven by hospitalizations, and we all know that hospitalizations in AF are the primary driver of healthcare costs. Second, there's nothing better than having a second independent trial, and this is the Miracle AF trial. This is done in Jiangsu province, and this was the ABC pathway delivered face-to-face by village doctors supported with telehealth medicine. So cluster randomized trial, usual care versus intervention with the ABC pathway delivered by village doctors, although they're called village doctors, as many in the audience might appreciate, many of them are actually not medically qualified. So this was usual care versus village doctor centered, delivered, telehealth supported ABC pathway. Primary outcome is shown here, the composite outcome, and you will see this approximately 36% reduction in the primary composite outcome in favor of the ABC pathway intervention compared to usual care, or usual care was enhanced usual care because we gave them additional advice and also literature in the usual care arm. Now, the secondary outcomes, I think, are really important because if you look at cardiovascular death, about 50% reduction with the ABC pathway, stroke reduction, something like 36% reduction in favor of the ABC pathway, hospitalizations again in favor of the ABC pathway. So this you will see from Miracle AF, even delivered on a face-to-face basis by village doctors, supported by telehealth, a clear benefit for patients with atrial fibrillation. This was the older meta-analysis that based on the observational type cohorts, but I show this because it illustrates obviously the A and the B and the C, the translation to mortality reduction, reduction in stroke, and the reduction in bleeding. But I think it's important to highlight this is irrespective of the location of the studies, the evidence. Europe, Asia, North America, you see clearly, irrespective of the region, ABC adherent management on all-cause mortality in this particular figure. There's other similar data for stroke, etc. According to region, this was still in favor of the ABC pathway compared to usual care. So, is to really put this into perspective, we have the ABC pathway recommended in guidelines from Asia Pacific and from China, as well as Korean Heart Rhythm Society guidelines, supported by evidence. I mentioned the AFFIRMO trial is ongoing, the SOS acronym in the US guidelines, and we have the ESC guidelines based on care. You will see the color coding. You will see how they are actually related to the other. Ultimately, bottom line, it's holistic or integrated care management of AF. Atrial fibrillation management is more than simply anticoagulation alone. It's really holistic care, integrated care, easy as ABC, or you could say it's an SOS, or you can say we handle you with care. So let me conclude. Chairman, ladies and gentlemen. Well, we have atrial fibrillation as a common arrhythmia with a global health care burden. Different regions and different countries globally have different AF risks, and symptoms and complications also therefore differ. The importance of AF-related stroke risk factors may differ according to different populations, and I gave some illustrations with regard to AF-related stroke or complications, as well as the risk factors such as female sex. AF management is more than anticoagulation alone, and there's that clear need for holistic or integrated care management, which has been associated with improved outcomes. And you could say it's easy as ABC, or it's an SOS, or we handle with care. And with that, thank you for your attention.